Hello, everyone. Thank you for being here. My name is Martin, and I'm going to talk to you about my work, EEG functional connectivity measures in outcome prediction of postanoxic coma patients. So firstly, what is postanoxic coma? Well, it's a comatose state derived from the lack of blood supply to the brain, mostly caused because of cardiac arrest, right? Well, as you might know, prognostication of these cases is still a challenge, and it's important because these patients put a lot of pressure on the intensive care units of hospitals and also their clinicians, and a specific prognostication, a good prognostication could be or could represent a relief to their families and caretakers. So most research in this field has relied on visual inspection of EEG signals during the first 24 hours of these patients, or even 72 hours. However, quantitative approaches are taking over, mostly because they don't need for training of personnel, they are fast, and they don't suffer from inter-rater variability. They are objective. Well, in this direction, we propose functional connectivity as a possible prognostic variable we could use for these patients. In this case, functional connectivity could represent interstatistical dependence between two brain signals recorded at the same time. Whether it's because of their amplitude, their phase, or other signal properties. This could allow us to obtain an idea of how the different brain areas work together or activate at the same time or whatever. So, but why is this functional connectivity important? Why could it be important in this case? Well, we thought it could make sense to use these parameters because of the synaptic failure and neuronal cell death that takes place in these patients, which would impair the normal communication pathways in these subjects. Also because there has been studies using functional connectivity in order to assess the consciousness states in patients. And also because there are very, very few studies using functional connectivity in this direction, which could mean that maybe these variables are complementary to the ones used in previous works, in previous studies. This way, moving on to the method section, we included 595 patients, 46 of them presented a good outcome, and 5-minute EEG recordings were extracted at 12, 24 and 48 hours after cardiac resuscitation. Well, I've talked about the good outcome assessment, but I will explain it now. So we used the 5-point Glasgow-Pittsburgh cerebral performance category, meaning that patients with a CPC from 1 to 2 were considered as having a good outcome after 6 months from the cardiac arrest. And if it was from 3 to 5, it was considered a poor outcome. As I told you, we used functional connectivity measures. We included 3 of them. The coherence, which is a frequency-based method, phase locking value, time-based, and the multiple information, which is an information theory feature. This way, this could allow us to have a more complete perspective of the functional connectivity of these patients. We then fed those features to a machine learning algorithm to assess if with these features, we could predict which patients were going to recover or not after 6 months. However, there's another question. Do these variables contribute to the research that has been already done in this field? This way, we selected some features, EEG features, that are not related in any way to functional connectivity in another work from Sunil. et al. Because it had the highest sensitivity we could find in literature. And we trained another 2 machine learning classifiers. So, to sum up, we had 3 machine learning classifiers, one trained only with functional connectivity, another trained only with non-coupling EEG parameters, and another set trained with both sets of features. Regarding the results, the classifier only trained with functional connectivity. Well, sorry, I forgot to say, our objective is to obtain the highest sensitivity with 100% specificity. That means that no patients that would present a good outcome could be misclassified, which is really important. So the best classifier, trained only with functional connectivity parameters, obtained a 51.2% specificity. It was trained with the features only from the 12-hour EEG segments. And it presented a performance really, similar to newly proposed methods, and better than the methods that are being used in clinical practice. However, the most significant result from this study arises when we combine both sets of features, the non-coupling EEG features and the functional connectivity features, which create a classifier which obtain a sensitivity of 73.1% at 100% specificity. This improvement in classification may be explained by the high sensitivity, 100% specificity of the non-coupling EEG features, which and also the high generalizability of the functional connectivity classifiers, as we can see here, because the 2 curves, the training and the test curve, ROC curves, are really well fitted to each other. So, as a conclusion, this was the first study characterizing functional connectivity in various frequency bands and also its evolution in time in this kind of patients. We obtained a classifier with only trained with functional connectivity with similar performance as newly proposed methods. And we also obtained a classifier with better results than any other classifier we have seen in literature. So, hopefully you have found this interesting, and I would be glad to hear from your questions. Thank you.